So let's come to the important part now. What we are going to start now is everything from day one, whatever we have covered. So I want all of your attention. Please come back to Google Meet. Don't use Instagram. It's the judgment day, actually, right? Are you all here? Yes, no?
Yes,
Yes,
sir.
sir.
Yes, sir.
Good. So this is the case appraisal. The name is Mr. ABCD, 66-year-old male, who is a shopkeeper by profession. Side of dominance. We always say side of dominance, not the hand of dominance. Whenever you're writing a case, please make sure you're writing side of dominance instead of hand. Okay. And then address is Physiotax Nagar.
Yes.
This is IP number. So IP date. When was he admitted to the hospital? So that was 5th May 2025 in XYZ floor of XYZ department. Let's assume a physio has taken an assessment on 16th of May 2025. See the chief complaints here. The patient complains of inability to move the left leg, causing difficulty sitting and inability to walk and perform everyday tasks. He also complains of shivering movement in the left leg while placing the foot on the ground. Basically, this is the complaint of a patient in his own language. If we speak in terms of medical terms, then it should be something regarding the clonus. Try to realize that whenever we are writing a chief complaint, it should be very layman. He also complains of generalized body weakness. Apart from that, he has also had pain in the left knee region for 1 week. So anybody has to comment here anything which you feel can be wrong here based on the knowledge which we have given in 7 days.
It has mentioned the duration, like since when. It has also mentioned like what type of difficulty the patient is facing, but main complaint I'm not able to see. Like what is the main reason?
When we are writing chief complaint for physiotherapy case, we are focusing more on what are the musculoskeletal problems and the inabilities or difficulties they have relating to body movement or doing the activities, or how it is restricting them basically. So we are not mentioning the main medical symptoms here. Okay. And we are asking for our party. That's where people make a lot of mistake. If pain is where we also have implications. Okay, I understand. So we mention pain. And in chief complaint, it has to be more regarding our movement related and activity participation, activity limitation, activity, participation restriction. Basically that is what needs to be focused. So this is acceptable chief complaint because it is in layman language. It is focusing on what the patient is suffering from physiotherapy perspective, and also it has mentioned one symptom and then the duration of that. So let's go to the history. He's a 66-year-old male who was healthy 1 month ago, then suddenly experienced an episode of mild giddiness. All on same date around 5:30 p.m. Taken to an hospital, evaluated, found he had TIA, transient ischemic attack. He recovered and he was discharged. Then after a few days, he experienced fall due to weakness. This time it was from another, like approximately 10 feet, resulting in fracture of D12 vertebra. He was again taken to an hospital where the initial management of fracture was done. Considering his neurological symptoms, he was later admitted to Neurospecialty Hospital in Bangalore for further evaluation and management of his neurological issues. After being discharged from there, the patient visited Physiotax Hospital on 15, don't laugh guys, on 15th May 2025, seeking a comprehensive, complementary and holistic treatment approach. He consulted Dr. Adam Rashtala, who is an Ayurvedic practitioner, and diagnosed with Pakshagata, which is a Ayurvedic name for the hemiplegia or stroke. So he's currently undergoing Panchakarma treatment at Physiotax Hospital and also has been referred for physiotherapy. Physiotherapy assessment for patient was conducted on 16th May 2025. So again, there is no mistake here in the history of presenting illness, and this is how it should actually go. So every detail is provided: what happened, what treatment they did, where was he admitted. After that, okay, so 3 times he was admitted, admitted, discharge. So every center he goes, what action they have done, that needs to be present in the history of presenting illness until you are performing your assessment. That is physiotherapy assessment for this patient was conducted, that you are conducting. So you are taking his condition and bringing it to present date, what is happening. So that is how you report for the history of presenting illness. What is past medical history? Patient has no history of systemic hypertension, no history of diabetes mellitus and other metabolic disease. If he had the history of hypertension, then how much of years he had, and if he is taking medication, that medication also be reported in bracket. So that completes the form of writing the assessment. Coming to the medication history, so we have to make a tabular column like this: medication, injection, dosage, route, frequency. So how much of dosage he is taking, how many times he is taking, that everything has to be reported in detail. Surgical history he was not having. Family history, if it is there, you have to draw a family tree and then you have to report what disease he is having. That should be very relevant. Coming to the personal history, that is His diet, that is mixed, appetite is normal, sleep is normal, 6 to 8 hour on average. If it is disturbed, then you have to mention the reason in the bracket why it is disturbed. Then in bowel, normal, twice a day. Then bladder, normal, 3 incontinence questionnaire tool. So basically what we do here is we just ask the patient. The patient said it is normal, it is not normal. Based on that, we report. We don't try to identify or use any tool for this. So you can take that tool. Based on that, you will be able to identify whether the patient is having moderate bowel dysfunction or mild or severe bowel dysfunction. So that you have to report. But I see very less people doing that. There is a mistake there. Normal twice a day. So how do we consider that it is a normal? You use a scale, neurogenic bowel dysfunction in neurological cases. You will be reporting it as per the standards. Again, habit, no habit of alcohol, tobacco, or drug abuse. So Lasima, can you tell anything regarding when there is a history of smoking, then how do we report in cardiac cases?
Yeah, if there is history of smoking thing, then the first thing that you have to understand is you have to calculate for the pack year. That will give you the severity of how intensely the smoking habit has affected on the patient, whether it is related to the current chief complaint or not. Once the patient has a habit of smoking, it is compulsory for every one of us to calculate the pack year. So how do you calculate the pack year? Is you calculate the number of years. Like say, for example, this patient has been smoking for 2 years, or keep it for 1 year. So 1 year means 365 days. And what you do is like you ask the patient how many cigarettes they smoke on a daily basis. So say, for example, if the patient smokes 1 packet of cigarettes, so which is approximately 13 cigarettes, I believe, in a packet, 12 or 13, I believe. So what you do is like to calculate the pack here, you multiply the number of cigarettes in a packet into the total number of days. That is, if it is for 1 year, 13 into 365 you do, and you get the number, and that is the pack year. That is what you document as the pack year. And another thing, once you do this, you will understand there are classifications where according to the pack year, you will understand the severity level. And another thing is that in the observation part, you check for the nicotine stain. Once you get there is a habit of smoking in the personal history, it is very compulsory for you to check the nicotine stain. How you will check and where you will check is like between your two fingers, that is your index and middle fingers. Between those two fingers, you check for the cigarette stain. And if you would check for thumb and index, tip of the thumb and index for the BD smokers. If they are smoking cigarettes, you get the stain between their, I would say, medial border of the middle and index finger. If they are BD smokers, they will have stains over the tip of their thumb and index finger, because the holding of BD and cigarettes are different. People hold BD with thumb and index finger, and cigarettes they hold with index and middle finger. So that is what you find out and do if you find a tobacco smoking or habit in the habits part. And there is alcohol also. If you find the patient is a alcoholic person, you calculate for the peg, how many pegs per day they are taking, which I'm not very sure of. I haven't done my research on that. So this is what you will calculate if there are any habits.
Thank you so much, Dr. Lasima, for that commentary. So you understood that it is not just a sentence that you write while reporting, but there is a proper logical science behind reporting, even the habits. Let's come to the environmental history that you have to frame for hospital as well as the homes. For hospital, you have to mention what is the facilitator. First facilitator, what is mentioned on the screen. Availability of physiotherapy and rehabilitation equipment is a wrong statement. You have to mention a physical object or environment related thing that facilitates, or either environment or either mental related thing that facilitates the rehabilitation process. You cannot write that. Okay, if you don't have anything, then if you write that, it's okay to some extent. But you see the second facilitator there, wheelchair accessibility and railing on the bed helpful for bed transfer. It is a better statement there for facilitator in the hospital setting. Again, barrier, lack of food options and difficulty to change dress comfortably before and after panchakarma is a barrier for a patient. That is also acceptable. Discomfort in accessing toilet or bathroom is a barrier, because if the patient is in general ward, then you will be having problem to reach out to the common bathroom or common toilet. So a lot of time patient will tell that they have difficulty in that. So you have to not write your own statements here. That should make sense with the patient which you are treating. So better is to ask them, take their opinion, understand their problems, then you report. Just don't report availability of doctors or availability of physiotherapists. The department is there, that's why he is there in the hospital. So it doesn't make any sense. So what is the facilitator and barrier for home? Family and comfortable surrounding reduce anxiety and confusion is a facilitator. Obviously, it is a psychology, mental part. Presence of family. Again, what is wrong here is they are reporting, just to fill the columns, they are reporting same things in different paraphrased sentence. So that should also not happen. It should be something different. If it is not there, just leave it blank, right? Like if you think that two components are there in the entire problem list, then you don't try to add on something which is not there. What is there you add, what is logical you add. It doesn't matter if you have many problems or less problem list. It doesn't matter at all. If there are many problem lists, you have to write many problems. If there is one or two, write one or two. If even if the space is blank, let it be. Don't try to manipulate things. Coming to socioeconomic history, marital status is married. Four children are there, two are son, two are daughter, and breadwinner is his son. He is not earning. So to go into further detail, we use one scale, that is modified Kupuswamy scale, right? So this is reported as per 2024. So you see here, education of the head is high school, then occupation is small business because he was a shopkeeper, and then his monthly income lies in the 44,000 range. So therapist has rated as per that. Okay, so he classifies that he is a lower middle class patient. What does this help us to understand? Lower middle
He
class.
is able to not like afford the treatment maybe fully.
Yes. Is he able to afford the treatment, or is he able to, if we prescribe certain things such rehabilitation equipment, whether those are braces or some devices which are expensive? So that gives us idea what we can do, what jugaad we can do, right? So you have to determine here itself what type of equipment you'll use if the patient is able to afford, and what type of jugaad you will use if patient is not able to afford. So if the patient is not able to afford a dumbbell, then you have to fill the bottles with the sand and then insert the pipe on both sides and try to lift. If you don't have sandbag, you just open a plastic, fill the sand and close the plastic and keep it on your leg, tie it and then try to lift. So these are certain things we have to determine. We are able to understand by the history, by their socioeconomic history. History is what gives us proper understanding, basically. I hope you understood this. Coming to the pain history. So now what a lot of people do a mistake here is they write a combined pain history for the entire body. No, if a patient is having left knee pain or back pain, both has to be reported separately. So here you see, when you're reporting, you put one left knee. Okay, this is the first pain which the patient is having. So then you have to draw two NPRS scale, right? Not just one and just put on aggravation. You just don't do that. It is called laziness in simple language. So you have to do, what you can do here is you can put left knee, that is the first type of pain the patient is having, on movement on or on aggravation. What is the better way to write here? Instead of writing on movement, you can write in on knee flexion. So be very specific. Okay, so whatever joint you are referring to, if it is shoulder, then if abduction is causing pain or not, if flexion is causing pain, you specify then and there itself. On flexion and abduction, it is grade 5, NPRS grade 5. So like that, you have to be very specific. You see here, it is interesting or boring, guys? Let me know. 28 people are constant. I see. I feel this is helping you all.
Yes,
Should
sir.
have
Helping
been
a lot.
Yeah, this session should have been attended by many, but yes, you deserve it. Very good. Come on. So you see symptom or pain history, left knee. Number one, on movement. I said this person, if this therapist had specified that it is on flexion or knee extension, I, as a new therapist, would have got more idea about the pain here. So you can see here, on movement, grade 5. So one scale is drawn, done. At rest, it is grade 2. It is a mild pain. So this is how you report, and then you put one diagram and specify where there is a pain. Okay, so you show that properly, and then you report the characteristics of pain. So now which format it is in, it was being taught in the first session itself. So which format it is in and what format you are using in your clinics, just try to understand. There are two formats, right? One is the basic one. Yeah, our students are not even following the basic. This is the basic one, OPQRST format for pain, right? So a little more advances what Dr. Abhijit has taught, that is nothing but Socrates. So I understand not all complicated things can be used in clinic all the time. Just go with this. At least you by heart now itself. OPQRST, onset, provocation, quality, region, severity, time. So I have to appreciate this person who has taken the assessment, that he has used at least a good format of reporting the characteristics of pain. He says that onset was gradual. It is provoking on knee flexion. See, he has done his job here nicely. So he is now telling it provokes on knee flexion and when the patient is standing. So weight bearing is causing him pain. So you have to be very careful while you are bearing weight when you are giving the treatment. So it is all logical science, right? So if we give proper attention to the assessment or read, if this assessment is nice, and when you read it, you get proper idea how to treat the patient and what not to do. So he's also mentioning region, whether it is radiating or not. It is not radiating, just the region is mentioned. Crepitus is positive. That is a good information he has given there. So we can suspect based on the age that he might also have osteoarthritis, right? If the knee X-ray is present, we can again correlate and confirm that. Severity, it is moderate, and then time, it is 1 week. This pain assessment which you saw from here till here, in the scale of 10, how much you will rate how he has done the assessment? How much you'll rate?
Maybe a 6 or 7. 6,
6 or
7.
7. Okay, so you know the reason. There were few mistakes here, so that we have already commented. So let's move to the objective examination. On observation, build, he has mentioned poor build. That is good because he has not used BMI calculation. Only then he can write about the definitive terms such as endomorphic, ectomorphic, or the mesomorphic. So he has written poor build instead of ectomorphic. So that is logical. It is not a good thing to do, but it is logical. It is not a blunder in this case, right? So
But
mode
it
of
would be better to
ventilation.
mention, right? That's like ectomorphic,
No,
endomorphic.
if you don't calculate BMI, height and weight based on that, if you don't write, then it becomes wrong. So you have to, if you are just observing and telling he is poor or normal or heavily built, then you have to use such terms. But if you
Okay.
are doing the BMI calculation properly, then you have to mention the terminologies such as endo, ecto, and meso. So that's the thing. Mode of ventilation independent for neuro case, this much is enough. Pattern of respiration abdominothoracic, again this much is enough. Incision is not there because he's not having any surgery. Muscle wasting, he is mentioning general debility. Is this a mistake or is this not a mistake?
I think it's a mistake.
Yes, please go on, explain the rationale.
You have to be specific with the wasting that has happened because you can measure the wasting on bilateral sides and you can measure how much wasting has happened. So that will be more specific.
Yes, thank you so much. So this is how you got the idea, right? So when it comes to pressure sore, there is no pressure sore. So you report no pressure sore, not a problem. Skin texture wrinkled and thin. So what understanding does it gives us? It is nothing but this patient is having more chances of developing pressure sore. So that triggers, that alerts us and makes us aware of this particular thing, so that we prioritize the positioning and prevention of the pressure source. Deformity again is nil. Assistive aid, it is a wheelchair, but can ambulate with framed walker or support. So here also he is mentioning about two possibilities. Gait, he cannot ambulate, so it is not assessed. So this is how he has reported. External appliances are not there. If it was there, then we have already thought what to do here, what to add here, right? So such a like IV cannula, if it Ryle's tube is there, Ryle's tube, or Foley's catheter. So all those things come under here, this part. On palpation, warmth, painful site. So here you see he has specified he's assessing warmth for the painful side. Warmth does not necessarily means to the body temperature. That comes under the vital assessment, under the examination part. Okay, please try to understand. Warmth here refers to any inflamed side which is having heat. Yes, there was a pain in the left knee and the left knee was warm. How do we assess that? We assess with the dorsum of our hand. So you have to be very specific. These are very tricky part. So we tend to confuse. You should not. Our goal in palpation is to find out the local warmth as a matter of inflammation. You have taken pain history, so you have to correlate and you have to try to assume that there is inflammation or not. Redness is there or not. There is no redness. Tenderness is there. Yes. How much grade that you have to report. He is also reporting nicely there. Again, tone. Since there is a general debility, yes, Dr. Abhijit.
Yeah, I had this doubt. So when we are considering bed sore and swelling, edema, and the type of skin, do we have to go specific, like use any outcome measure as such?
Actually, we can use, but in palpation we don't. We just mention there is there or not, and then in examination under this part also we have mentioned a lot of things. One second, where is it? The tone, here we are just mentioning general debility, and then muscle wasting also we are just mentioning general. He has mentioned general debility. He has not specified the location, but under examination he has assessed for the girth measurement. That will basically come down, so we can put that part in the below segment also. Yes, observation, we have to report the site and the location. I mean the severity just by the observation what we are able to find. That is same for tone also. We say it is flabby or not. Then later we confirm it is hypertonia, hypotonia, spasticity, rigidity, or flaccidity. So that has to be separated. Basically, you need to have idea in palpation to what extent you go, in observation to what extent you go, and in examination to what extent you go. Basically, you assess, you build the first floor, make things favorable for second floor to be built, and then you go to second floor, and then you complete building the second floor. So let's come to the examination, right? So higher mental function, he is first telling about status. That's what I have taught in the neuro higher mental assessment also. So oriented to time, place, and person, he is switch on, his body is switch on. How much switch on it is? E4, V5, M6. So again here the GCS is normal. What is his cognition? Again, MMSE 30/30 he is reporting. Again here, when you are reporting this scale, you have to report it very genuinely. Okay, just not like ChatGPT you have taken and then you are just reporting, because this particular test needs pen and paper. The patient has to draw. Okay, the patient has to draw. So if he's not able to draw, then we cannot actually grade. A lot of people tend to manipulate here. Second, like in the MPT presentations, you get caught because the patient is not the patient is not having the strength at all. How will he draw? And you are in the bedside like scenario, and then how can you like tell the patient to draw when the patient is in ICU? Basically, he is not well. So here only it is not status is only is not able to accept the command, but you are mentioning MMSC and grading it. But in MMSC, the patient has to talk to you. So these are all very simple blunders people tend to do that you should not do. Perception assessment, visual, somatosensory, auditory, body scheme. Again, this is also having proper structured methodology. But for real life perspective, it is accepted that everything cannot be tested. So he has done like this. He has mentioned left side is all normal, right side is all normal. Left side visual is normal, somatosensory. See all these things. If you want the procedure, you can ask later. We'll explain. Okay. So I'm just skipping many things because I have to consider time as well. So please understand. Speech assessment. So here you see he has considered that there is a mild speech difficulty. ABCDEF is a screening tool. So you understand articulation is normal. That means he is able to speak, but articulation is delayed. His speech is very slow. Okay, he's speaking, but he needs time to articulate, like that. Breathing and phonation, the vibration which comes from the vocal cord, whether there is a problem with that, like that, or whether he is speaking properly like a proper male, or he is having the hoarseness, that you have to understand, right? When comprehension, we are telling he is able to understand our speech or whatever we are speaking, it's been delaying for him to take that you have to understand. Then differences where you're speaking like a foreigner, and not like that, guys, just trying to wake you up. Differences where your fluence is not correct, right? So you have to understand that. So expression while he's speaking, whether he's aggressive, whether he requires a lot of effort to speak, or his speech is very spontaneous, that also you are able to detect. So basically, ABCD helps you understand whether the patient is having problem with the speech or not. It's a very simple tool. Next, let's go to the cranial nerve examination. So good thing, properly, again, there is a segregation between sensory part and motor part, considering the cranial nerves. So olfactory nerves, he is telling normal because he has used coffee powder. So I'm happy that he is using coffee powder and not just normal, because when we were sitting in the presentation of the time, so sir asked the question. So for what test you have done? So the person was telling, I have opened the I have opened the tonic bottle and made him smell that, and then I declared that it is normal. So logically it might be okay. Our logic says it might be possible, but see, we have to go with what textbook says. So camphor, asafoetida, coffee. So these are the things which are tested and proven that these can be standardized to use for the olfactory or smell testing. So that has to be done. So if you are using any other component which is standard, such as asafoetida, then you have to mention that is that you have used. So just simply don't write normal. Okay, optic, he has said normal. So anyone would like to comment here? What can be the better term here instead of normal? Normal is normal. Okay,
Like mention like the Snellen chart or that like Jaeger
very
chart,
good.
like something.
Very good. So it has three components. So field, acuity, and color. You have to identify. You have to report all three here nicely. So since it is normal, might be he has written normal. If any one of was not working or field was decreased, he would have mentioned that in the bracket. So that becomes correct in this case. The reporting becomes correct. If it is abnormal and you are just writing abnormal, it is wrong. People will ask you. I mean, the evaluators will ask you and nicely roast you. Oculomotor, trochlear abduction, ocular hypokinesia. Okay. So he is specifying that there is a delayed movement of eyes, not specifying to what exactly, because each and every nerve is having different movements, right? So it would have been better in that case, but still he is writing it nicely. Well and good. Okay, not a problem. Trigeminal sensory, again he has assessed for sensory, separately he has assessed for motor. He has used jaw jerk. Again, jaw jerk is affected. That means motor part of trigeminal nerve is having a little problem. Sensory facial sensation is intact. So that's what he is able to find. Again, this is also okay, not bad. Facial, you see, sensory and secretory is normal. What is secretory? How do we test for secretory? Again, here we are able to find that this person is manipulating, because we might not have the apparatus of testing the secretory functions readily available with us. How many of us have that papers? Certain things are easily catchable by the evaluators. So I hope this is helping you present your cases in front of your respected staff, right? So motor, lateral half facial expression reduced. Lateral half, left half facial expression is reduced. Okay, not a problem. This is good. But he should have also mentioned which type of movement. That would have been even more better post graduation level. So vestibulocochlear, rubbing, whispering, and everything is normal. He says he has used the tuning fog. Also mentioned the frequency, that is appreciable. Glossopharyngeal vagus uvula central. I am happy. At least he observed something. Speech is slurred associated with hoarseness. Okay, that is one of the characteristic features of the problem with the glossopharyngeal and vagus nerve. And gag reflex he has not elicited. Very genuine guy. He's telling not elicited. Spinal accessory. Now here I have to appreciate this person because he's reporting all the muscles separately for both sides. Sternocleidomastoid on right side is having 4/5, and also he's writing here MRC grade. That is again a good point. So we are understanding he's assessing MMT. He's using MMT to declare whether the spinal accessory nerve is having a problem or not. Then here he's telling trapezius. That should have been upper trapezius. No, not a problem. At least he has reported that much. So this is how you can do your spinal accessory nerve assessment. Hypoglossal, normal tongue movement he has written. Since it is normal, it's normal. If it is abnormal, then he has to go into more detail about that. Let's come to the sensory examination, right? So you see here, very nice and detailed tabular column, unlike the reportings which we do in our clinics. You see, location, upper extremity, lower extremity, trunk. Sensation, right side, left side, right side, all for all three components. That means basically entire body is covered here by means of his sensory assessment. So where he has touched that, where he has tested for sensation, that should be by default understood that it is dermatomal key point. As graduates, as physiotherapists, we need to understand that pain assessment or whatever this is done, it is not vaguely touched on the skin like that. You have dermatomal key point, based on that only it has to be touched. That is the rule of sensory assessment. If somebody is not following that, then he is wrong. And again, sensory for the deep sensation, the assessment should start from distal most part, distal most joint, and then it has to go to the proximal part. If you are directly going and telling the patient to do this part, then it is wrong. So that is the rule of sensory assessment. What is the first rule of a lot of things are there actually. What is the first rule of sensory assessment? The cognition should be intact. Okay, if I start to tell, it will go. I am trying to restrict myself not to go into much explanation, just stay with the logic. That's what we did with neuro also. So to explain, a lot of things are there, and it's really interesting. Somewhere in future, maybe we'll do that. Okay, if people are leaving, joining, but I see 26 are there. Not more than 15 minutes I'll take, guys. We'll shut down. Okay, stay here. I think this is helping you all. Please, somebody is sending Nepal's flag also. Okay, so deep. So you have to see here pain, touch, temperature, and pressure. He has not assessed for the temperature. So he's mentioning that genuinely, but pain is intact. So pain and temperature is carried by the same tract. So we anticipate that the lateral spinothalamic tract is intact. So this is the knowledge which actually should be having properly. So only then we are able to understand what component of sensory tract or sensory system is affected basically. So based on this only, I have asked one question in the group. So based on comprehensive sensory examination only, we are able to diagnose a lot of neurological disease, because there are patterns of sensory loss such as talking gloves, sensory loss pattern, hemisensory midline loss will be there, saddle anesthesia will be there, and then we have mononeuropathic or patchy sensory loss. So we detect that, we have to find that out, not just writing plus or minus, present or absent in the reporting. By means of this, we have to find those problems. Then we are able to understand. Patchy means for brachial plexus injury, saddle anesthesia is related to your chorda equina, which was discussed, and then midline is related to your central cord syndrome, which is a type of spinal cord injury. So this understanding should be there by means of our assessment. So that's why we are doing actually assessment, not to fill the pages, but to find the reasons. Right? Please understand. Okay, so we'll move to the cortical part here. Again, cortical is affected. Yeah, brain lesion is there. So we understand, we anticipate there is a problem. This is correct, but he has written plus and minus here. That should be written. Is that correct or is that wrong?
It's correct. Yes.
What are the types of sensory deficits you tell? Deficit or abnormality, sensory abnormality.
Altered sensation.
Whatever in. So a patient having diminished sensory, he is able to feel, but not as normal as how normal person feels. That is also a problem. And he is not able to feel at all. That is absence of sensation. It is also a problem. He is having increased sensitivity, like he is having increased pain sensation, aggravated, exaggerated sensation. That is also a problem. So by means of plus or minus, how are you able to tell the reader that you are telling the patient is having diminished, or the patient is having absent, or the patient is having exaggerated? How will we differentiate? That's why the entire reporting system here is wrong. Plus or minus should not be used. You can directly use present, diminished, absent, or you can use Asia 3-point sensory grading to determine whether it is 0, 1, 2. 1 means diminished, 2 means normal, and 0 means absent. Okay. In terms of pain, you can again put here comment, he is having hyperalgesia, allodynia. Like that, you can mention if anything you are able to find. So that becomes very clear for the readers to identify what you have found. This case, it is not, I am not able to understand for superficial sensation, basically. I hope you got the point. Again, the
So
motor
basically,
system. Yes.
so if you've taken Asia scale to like write the grading, so it would have been better in this.
But you should not test for the entire Asia scale. Asia scale is
Yeah.
having a lot of components,
Yes, sir.
right?
But like
It is
your
having,
sensory
it is
part, if
having
you're
5.
touching means, yeah.
But you have to mention graded as per Asia's 3-point sensory scale. If you mention that, it is fine. Then you can write 1 to 3. If you directly write and don't give proper context, then it will be wrong.
Okay.
In that case, many of the people have problems. So it is not a spinal cord injury case. Why are you using Asia 3-point grade? In that case, you can write present, absent, diminished. And then below you can write if it is there is an exaggerated sensation for pain, basically. The exaggerated sensation will be for pain most of the time. So you can write that.
Okay. Thank you,
Understood?
sir. Yeah.
So that becomes logical and safe space for you to get away with the roasting that happens by your teachers. I mean,
Thank you, sir.
okay. So motor system, voluntary control, side, right, left, upper extremity, hand, lower extremity. I am giving resource. Okay, I'll give you, that will help you understand how we are reporting. Again, what is the mistake here? He has used brainstorm recovery stage to like mention the voluntary control. He could have used voluntary control grade instead of this to be more specific or more better. Still, he has used this, and a lot of people are using this acceptable. Something is better than nothing. So he is reporting isolated manner. That is again good. He is not telling the patient is having brainstorm recovery 5 or 4. He is telling upper extremity left side is 5, left side hand is 5, and lower extremity on left side is 4. So this is good. Muscle tone as per modified Ashworth scale, but there is no modified Ashworth scale. He's telling no increase in muscle tone, which is basically the least grade of the Ashworth scale. Basically, there is no increase in tone, so he has not mentioned the tabular column. If there is increase in the muscle tone, then you have to mention what muscles are spastic, right? So again, lot of things are there here. Spasticity and modified Ashworth scale is one of the best scale to held people and roast them nicely by asking grade and findings. So be very perfect with this. In future, maybe if we get time, I'll explain you. There are a lot of things where easily you get caught. Suppose I am your teacher, evaluator, coming to see your case, and my mood is not good, and I have some grudges on you, basically. So even if you're 100% prepared, I know certain things to ask you and roast you nicely. So that critical is our Ashworth scale based on the concept. So you need to be very careful. I'm just giving you awareness. If I start explaining, it will be too much time consuming. Reflexes, we'll see. So what problem do you see here? Superficial. He has reported right and left. Abdominal reflex not assessed, not assessed. Okay, fine. Plantar reflex is telling 2 plus. So you need to understand that superficial reflexes are not graded the same way deep tendon reflexes are graded. So here the better way, also told during the classes, better way is to write the response directly instead of mentioning the grade. It is not correct. Superficial are not graded this way. You can write present, diminished, absent, or you can simply write the response. Plantar is there, flexor response, or extensor Babinski response. You have to write that. That will be more better, right? So this is wrong here. You might feel that the case was very detailed, very nicely framed, nice tabular column, but you see there are still a lot of mistakes. So this is a moment of realization or reflection to what you have been doing in the clinics. So even if this case is having this many mistakes, you just think how much more mistakes we do as beginners or inexperienced or who have not thought about this thing. These are very important. So again, here deep tendon reflex, jaw jerk, he could have not used it here. He could have started with biceps, triceps, supinator, knee and ankle, but he has used it here. It is wrong. He should have kept it there up only in the cranial nerve assessment. Since he have assessed there was no need to assess here again. But he has reported it's not so correct, but it's okay. We'll accept because a lot of effort he has spent to assess and report the patient, right? So this is how knee jerk and all those fine. Based on the condition, it is how it is. So let's move to the what is the mistake here? After the reflexes, he has directly gone to the muscle power. That is MMT. After reflex, you're writing MMT is wrong. What should be coming before that? Who can answer? It is not for reporting, it is for logical also. Like again, the same example. Reporting muscle power first is like building second floor before you build your first floor. Yes.
Range after reflex.
Yeah, that's what. Range of motion should come before muscle power assessment. So this is a big blunder here again. So he has built second floor without building first floor. So you need to first understand the patient is able to move his hands or not, or legs or whatever extremity it is. Only then you can go with the testing of MMT. So you need to make sure that you are able to get the movement from the patient, then you can proceed with the muscle power. Register in your mind, even if you are a clinical practitioner who has nothing to do with assessment presentations or assessment documentation, still you need to take care that you assess range of motion before doing the muscle power assessment. I have told you why sequence is important in neurological assessment during the neuro session as well. So you see whatever things you have been writing in the assessment sheet till now in the hospital assessment. So many of the juniors which are there, we see, right now you realize how much of the blunder you are doing. Somebody is writing gait first, somebody is writing bowel and bladder later, somebody is writing sensory assessment at last, somebody is writing functional assessment before range of motion. This is all blunder. This is having no meaning. So you are just building fifth floor before building the first floor, then suddenly first floor is on top of the ninth floor. So there is no meaning for that. That's what we are doing. Actually our assessment are like our dreams, where we actually start our journey on bike and reach home with the horse. So that's how it is happening. So you need to understand that will not work. So again, MMT still he has reported, okay, fine, good guy, one chocobar from me. Left side is reporting there is a little bit of weakness. So 3, 2 plus. Again, one more thing, he is using our 10-point grading system instead of just the normal normal MMT assessment of the MRC. He is using Daniel and Worthington. That is good. That is worthy. He is using Worthington scale. That is worthy. And I'm telling you, as a physiotherapist, don't feel lazy to by heart 10-point grading for MMT, because that is the least amount of like capabilities you should have as a physio. Because MMT grade 5 is done by even the doctors without keeping the extremity in the anti-gravity position. So as a physiotherapist, your level should be even more higher than that. You should feel proud to learn 10-point and use 10-point MMT rather than being very lazy. It is very easy, guys. Very killer logic is actually in our language. So very easy to understand. Once you understand the concept, that scale you'll not like forget. You have not made efforts. You have seen, oh, I can't use this. This looks very, very complicated. First, you go jump into the water, then you'll learn to swim. Before that, you cannot learn, right? So we'll move a little faster again. Again, one more point here. Trunk MMT also he has focused. He has reported that, but he has told he's not assessed due to patient state, because trunk flexor extensor needs the patient to come out of the bed. So that is not possible in hospital beds where we have upper railing and like top railing and bottom railing. So that becomes difficult here. And it is difficult, not easy to assess. Don't assess. Nobody is telling you to give 420 world ka jhatka and make them run. No. If he is not able to stand, not able to walk, don't aggravate. You report not possible. That is for safety. Okay, it is your logic where you are giving priority to the things which is mattering most at that particular stage. If the patient is flaccid, you have to facilitate. If the patient is having movement, then you have to strengthen. So that's the basic logic that you need to take care. Range of motion, you see again, right, left. He has reference value also he has provided. Active he has reported. Passive he has reported. Very nice. Okay, but he could have, in ortho cases, he should mandatorily report end feel also. Here this was related to stroke and the Brunstrom was more than 5 basically. That's why he has gone for isolated assessment. Or if it was less than 3 or spasticity was there, then he should have gone to full Mayer assessment. I hope you all have seen what is full Mayer assessment and how it is taken. Again, explaining that is not possible out of the scope for tonight's class. That will be more logical in that case, and this is logical in this case because he's having isolated movement since he is grade 5. Isolate not completely, but yes, to an extent he's able to do. So he has reported in this way. Again, this is logical. I am happy with that, not a problem. So this is how he has reported everything. Coming to the coordination. Now you see coordination he has done because the MMT was generally the MMT was 3, 4, 4 plus. So you see 3 and 4. So taking a coordination assessment is possible and logical here. So he is rating there is no problem with the coordination, but there is a problem with the tapping hand and tapping foot. So again, coordination has a lot of limitations basically. So these grade 3 or 2 can be because of weakness also, because you see the lower limb strength was reduced. Okay, strength is muscles ability, but coordinations is cerebellum's working. So how are you so sure that this is cerebellum not working fine? It can be because your muscles are not working. That is a limitation of the coordination assessment, non-equilibrium testing. So there are limitations. You should be aware as a therapist. So you should not claim that this person is having cerebellar dysfunction because when the patient is having weakness. If the patient was having no weakness here, and then it was having this thing, there was reduced grade for non-equilibrium, then we tend to interpret that this is a problem with cerebellum, not with the muscle or corticospinal tract. This is again, tracks are different for both, so you need to have knowledge on that. Only then what I am telling you will be making sense to you very logically, or else it will be like, you will be thinking, oh, this guy is telling something I'm not able to understand. Let's go to the equilibrium again. He is telling standing normal grade 0. He tested that patient is not able to stand, then nothing he did further. That is very logical. This is how it should go. Then comes our balance assessment. And when it comes to balance assessment, sit to stand is, he has reported the balance scale here. He is not able to do the equilibrium test. Then assessing balance is not logical. He shouldn't have reported work balance at all. He should have told balance test not testable. Then he should have moved to functional independence assessment measure. That is also okay. So he has reported. Let's believe that, let's assume that he has reported it correctly, because again, in this also people tend to make a lot of mistakes. If you stand and start to take roast the people, basically you are able to find lot of mistakes. Even an expert can get caught in that. So again, out of the scope if I explain. Let's come to the other assessment. This is what he has seen, there was general debility or wasting. Then he has quantified the wasting. That is important. So you see there is a little bit of difference, but still it is considered normal. 3 centimeter, 2 centimeter, 3 centimeter is fine. Okay, but if it is more than that, then it is a problem. Again, next he completes the examination part, consider everything. He has missed bowel and bladder. He should have assessed that also. So he has missed it. So that is a problem, because that condition which we are dealing with, D12 vertebral body fracture with neurological deficit. So whatever is present below can also affect, including the bowel and bladder. But he has not assessed. That is a wrong step. He should have assessed. He has not assessed. We could have got more understanding on that if he had reported. So after that only he should have jumped to on investigation. On investigation, he will just write whatever is there in the report, MRI. So he has written it nicely, not a problem. Good. And then laboratory investigation, which was done in Physiotax Hospital on 16th May, he has reported what tests have been done, but not the values. That is again wrong. So if you are reporting complete blood count was taken, so you should have mentioned what is the value of that, so that we could have analyzed and we could have interpreted or taken care of few things based on these values, right? So coming to the medical diagnosis, now it is the very important aspect. Medical diagnosis, posterior circulation. This is what the diagnosis doctors do. When it comes to physiotherapy diagnosis, this is what we do. This is our part. So you see, medical diagnosis will have names of medical diseases, but the physiotherapy diagnosis will have those things which are more logical to us. So here he is telling 66-year-old male having left-sided hemiparesis due to posterior circulation TIA. This is medical with associated medical. Left knee pain, calf clonus, and mild speech difficulty. This is not actually a good physiotherapy diagnosis. He has found a lot of things. He should have kept physiotherapy diagnosis in a much better way. He has added medical terms more here. That is what you need to understand. Physical diagnosis or physiotherapy diagnosis will have things like left-sided hemiparesis. This is okay, I understand, because we deal with this. Then left knee pain, we deal with this. Calf clonus, we deal with this. Mild speech difficulty, some vocal exercise we can do. To a limited scope of physiotherapy, it comes under us. And then he should have mentioned these parts where he in problem list is mentioning lack of mobility aids and all those things. Again, this already we have discussed in very nice way, very detailed way. I'll not go again much in this. So these things could have been, he should have mentioned here limited activities of daily living for lower limb. So if you should have mentioned like that, then this diagnosis would have been more better. So you understand, you are not diagnosing Parkinson's. You cannot diagnose. You don't have right to diagnose. You cannot diagnose a medical condition. You are diagnosing what that medical condition is causing to the body that is related with musculoskeletal or those things that is like legal or ethical for physiotherapists to assess as per the definition what WHO has given us. So please understand, this is what our game, this is what is our field, this is where we have to work. So when we are proudly claiming that physiotherapists are able to do diagnosis, and then tomorrow you are telling I have good medical knowledge and I can diagnose migraine or I can diagnose multiple sclerosis, then you are ethically, morally wrong. You have to tell that condition is medical diagnosis, but because of that I have found that this patient is having problems with activities of daily living or pain in certain location, or he is having cognitive deficit or sensory impairment. This is what you work. This is where you have got freedom to practice and determine what you are going to do. So based on that only, he is telling he was having left knee pain, then he is setting short-term goal to reduce left knee pain. Again, this is very vaguely stated. He should have mentioned how much grade he will reduce in what time. That becomes smart framework. So all these things has to be changed in that way. Only then it becomes logical. So let's move to this. Goal also has been discussed tonight. So physiotherapy management. So he is reporting date. Then he is specifying the goal for which he has given what therapy and what dosage. This is a good, this is a good reporting style for the treatment which has been given. So you see, so these and all are the things which he has done. Again, conceptually we can criticize here. If I am evaluator, you are presenting, and I don't feel that this particular treatment is evidence based, then I can again question here. So you have to be ready with the logical answering or the logic which is there behind what treatment you have chosen and the evidence behind it. If you are well prepared with that, you'll never be defeated in the case presentations. So again, 3 days he has been treated same as previous day, but he has added another treatment, that is stand to ambulation, that he has reported. And coming to the progression note, again he could have mentioned it very nicely, like how we do for research: baseline assessment and post treatment assessment, or at least 2 columns, and he can write pain, baseline, and then during discharge. Like that also, if you report, then it will be more better, more comprehensive, and you will not have any questions from the evaluators or the people who are seeing. And again, to complete the assessment, he is writing about the advices. He is mentioning what is better for that patient. That is also a good thing. He is also writing it is not needed actually, purpose and all. Just write the advice professionally, that much is enough. This was not needed. This looks childish. This looks like he wants attention from the staff. Or the second thing can be, since I am able to see long dashes here, it is a chat GPT or AI generated, and then I am able to catch and roast him. And even if I don't, but as an evaluator, I will reduce his mark because the person has used AI to report this. Using AI is not a problem. Making use of it in ethical way is what we demand. Don't use it in for wrong purpose. So if you are using AI, maybe this tabular column has been created by the usage of AI, but it was given human touch and made it logical by removing what is not required. Then it should have been accepted even if the dash was present here. Please understand the difference. Using AI is not a problem. Unethical use of AI is a problem. So again, AI about the condition, because there are audience whom we believe who have completed their degree but still they are not able to understand. Then for them we are writing here. He has written it, not a problem. Then last good thing what I would like to mention here in this case is he has also given reference to all the treatment which he has used in this particular patient, and that is a good sign. So basically he has used cryotherapy, and then maybe he should have been giving some cryotherapy, as he has given an evidence for why he has used. So in this case, in this way, if you are doing a case presentation, then maybe you'll be getting good marks. Or this depth of understanding you have in clinical practice, maybe your treatment will give effect to the patient. That is what our main goal, primary goal, by organizing this series was. I hope this was beneficial for you guys. Thank you.
Definitely,
So
Aman. This was a best, like the summing up of all 7 sessions. I I heartfully appreciate all the 26 people, including the admins who have stayed, because this is where the true essence of our clinical series has come into play. Rather than we explaining each section like history taking, demographic data, and all, how practically we can apply all these things. And when one comes in the observation, what are the changes that will come in the examination? How to link one from the other, and how to move forward. Every single thing has been explained. Great effort, great dedication, and of course for the 26 people who have stayed here, you guys have won the relay, I would say. You are the true winners out of everybody who has joined for the series. Now you have gained the complete knowledge package.
thank you so much, Dr. Lasima, for the feedback. Let's come to the last and most interesting part, that we have very less audience. Maybe somebody will see this recording in future. They'll be proud of you. So the person who has win the treasure hunt is actually any guesses, guys? Who can be that? The first person who has got 15 out of 16 digits correct, and that is actually a very difficult job, but she has been able to do that. That is nothing but you got to know she is she, he is not he. So sorry guys, not a boy, but that lady is, you all should clap. That lady is no one else than our Shamita BC from Srinivas College. Again, the title is taken from Srinivas College. So the title of this series, the clinical physio of the series, goes to Miss Shamita BC from Srinivas College. Congratulations for showing the dedication, sweating effort, and winning this title. You will be given your full fees back You'll be given 5 super knowledge hunts free, and then you'll not be removed for 6 months from Physio Tax Gold, even if you are inactive. So congratulations.
Thank you, sir. Thank you so much.
We have come to the official end of this series, and I hope we have been living up to your expectations. So see you all somewhere in future in some other series. Until then, take care, be a good physiotherapist, because you have chosen a profession that changes lives, and we are here to change everyone's life for good. Signing off from Clinical Physio series. Goodbye.